jump, we can get through this next lecture. So you guys got EMED next for your test. Am I up after EMED? Do I get center stage after EMED?
Yes, sir.
Jeez, you guys got it so easy. What's wrong with this place? When I came through here, the whole thing was, of course, right, it was way tougher in my day kind of thing. Right? Came to school, walked here, uphill, over in the snow, barefoot, and the whole 9 yards. But it was, test was every Monday, Wednesday, Friday was the rhythm back then, right? So the big joke was you could study for any test in 2 days because that's pretty much what we did. It was just study and don't, and study and don't. All right. Platelet disorders. And just for planning purposes, right? So next lecture, we're going to do the hypercoagulable stuff, the thrombophilias. And then the last day of lecture, we will cover the transfusion reactions and do a quick review for your test. Okay? All right. I assume no questions on the last lecture. You guys are killing me. All right. The usual. All right, platelets. You know what? By now, we all know what the role of the platelets are, right? And then thrombopoiesis. What's thrombopoiesis? Right, reduction of the platelets, and then the key there is the thrombopoietin, right? Primary growth factor. All right. Thrombopoiesis. Platelet production takes place where? Bone marrow. Right? And we all know this, right? The megakaryocytes end up going and splintering off and creating all your tons of your platelets. Controlled by TPO. It's that usual feedback loop, right? Right? Body senses low platelets. What produces the thrombopoietin? Liver, right? Which then tells the bone marrow to kick out more platelets. Easy enough. Thrombopoietin, right? And then your platelets. Job of your platelets, platelet aggregation, stopping the clot, yada, yada, yada. You guys good with all this. Lifespan, so platelets, 5 to 9 days. Okay. Not so good. What is the RBC lifespan? 120 days. And then normal, this says 150 to 422, sure. 150 to 450 is what I think is normal. Right? All right. So there it is. Right? Your pluripotential stem cells, go ahead, produce your megakaryocytes. What happened here? Megakaryocytes shoot off and splinter off, and you produce all your tons of your platelets. Right? All right. General approach. Sure. Abnormal CBC. Rule out pseudothrombocytopenia. What are we talking about there? Since I have no lab techs in here, now that you're all lab techs at the end of this course. What's going on with the thrombocytopenia, with the pseudothrombocytopenia? Yeah. So pseudo falls, thrombocytopenia. Right? You run it, you get a result back, that's low. You're like, okay, it's low. But then if they do a differential on it, somebody looks at it under a slide, they see a bunch of platelet clumping. So the machine isn't reading it properly. Right? So it's artificially low. So if you order a test or whatever, right, and you get a diff back and you see a bunch of platelet clumping in there and your number is low, what are you going to do? Reorder it. You don't trust that result. Right? Because it's not accurate. It's false. Pseudo, it's false. It looks low because there's a bunch of clumping going on. Right? You guys got that? And then a qualitative defect. Right? So I have the platelet in numbers, but there's something else there. Like in the case of von Willebrand's, there's an issue there. Right? There's a uremic patient where the uremia is affecting the platelets' ability to do their job. So I have them in numbers, but they're not being effective. Right? It's a qualitative defect. And there's your pseudothrombocytopenia. That's what it looks like under the slide. Right? So somebody put this on the slide, did a diff, right? And they saw a bunch of clumping. So they should report that out to you. Right? And if you didn't get a manual diff, and you know your platelet numbers seem off to you, right? Your platelet numbers seem low to you, then you should do something about that, right? And I would start by repeating. So when you get a lab result that just doesn't make sense to you, take a step back. You probably need to repeat it to verify it, right? All right, quantitative problems, right? Increased destruction. ITP, immune thrombocytopenia, it used to be idiopathic thrombocytopenia when I came through here. HIT, we'll talk about TTP, HUS, right? So is it a production problem, right, in case of the bone marrow, or is it a destruction problem? Why don't I have enough? Production or destruction? And qualitative, I will talk about von Willebrand's. Some congenital stuff, and is it something that's acquired? Again, a uremic patient is the one I think about. All right, so first disorder of immune thrombocytopenia, right? Again, when you get confused and you're reading something in real life or on a test, go back to the words. Immune, right? So there, that tells you it's an immune process. There are autoantibodies that's targeting the platelets. Immune thrombocytopenia. Autoantibodies targeting your platelets, they're getting removed out of circulation from the spleen. Primary is the most common. Primary is idiopathic, right? So if we're going to say, hey, we don't know what the cause is, we can't figure out it's idiopathic, then you got to take the other stuff off the table. So first, rule out your secondary causes. Is it associated with some other autoimmune stuff? And we talked about this. Autoimmune things tend to run together. Right. When a patient has one autoimmune disorder, I'm always in the back of my mind, what's the next one coming? Is there an infectious process? Are there certain medications, lymphomas, leukemias we'll talk about next go around? And then how does this present? It's a platelet problem, and how do we say the platelet problems present themselves? With hemarthrosis? No, right? With petechiae and bruising. Often asymptomatic. Again, depending on how low those platelets get, and then often followed by a viral illness in children. That's the classic case. Kid is sick, yada, 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 fine, gets over it, and then a couple weeks later, this fixes it. Again, presentation, maybe asymptomatic, discovered incidentally. So you've seen this patient, right? You drew some labs on them for whatever reason, and they come back and their platelets are low. Or maybe they have some of the symptoms. Maybe they came in because they had this rash, right? Having that petechial rash. Typical presentation, again, you could mucocutaneous bleeding, petechial rash, easy bruising, maybe some fatigability. Again, with this we say the primary and most common is what? It's idiopathic. But you got to rule out the secondary stuff. So if they're exhibiting any of these systemic symptoms, you got to go looking for the other stuff. Right? Don't hang your hat that this isn't something else. Because like any of these other disease processes, if there's something underlying disorder that's causing it, you want to target the underlying disorder. Right? So if they're having systemic symptoms, hey, go looking for some other thing. Right? What else might be triggering this? As the platelet count falls, sure, right? So kind of that order of march, to get that dry purpura on the skin, right? And then the mucous membranes will kick in, nasal passages, mucomucosa, gingival. Got it. There's your wet on your oral mucosa, there's your dry. Now this comes in a couple different flavors too, right? So acute, less than 3 months. Usually following a viral disorder. 80% of the time it's self-limited, which is great, right? It'll take care of itself. Just keep an eye on it. 3 to 12 months considered persistent, and then greater than 12 is chronic. So what does this look like? That's your key. Isolated thrombocytopenia. Your platelets are taking a hit. What's your red blood cells doing? Normal? Low, high, what? Normal. Right? Everything else is normal. It's isolated thrombocytopenia. The problem set is strictly with your platelets. Suspect other etiologies if multiple cell lines are affected. What's it called if all my cell lines are affected? Aplastic anemia. All right. Additional testing, bone marrow might be indicated, usually not. All right. Overall treatment, reduce the risk of clinically important bleeding. General strategies, monitor and maintain platelets at safe levels. Right? So what does that mean? That means we said, what's our reference range for platelets? 150. 150 is the low end, right? So now this patient platelets are 90, but they look great, not having any bleeding issues. What are you going to do for that patient? Just monitor, right? In medicine, we have this tendency like we need to treat something. I need to do something about this. Sometimes the best thing is to do nothing, right? Watch. You don't really worry about it. But now, if they're at 90 and they're showing bleeding problems, are you going to do something about it? Yes. Right? So again, we treat the patient, not the labs, right? But generally, your platelets can get down to 50, right? My dad's platelet lives in the 60s range. Why? I don't know, right? But he lives in the 60s. Hasn't had a bleeding issue ever. Okay. Patients with no significant bleeding, yep, platelets, yep, right? So watchful waiting. It's sometimes in medicine, the best thing to do is nothing. All right, treatment. So if you got to treat them, steroids and IVIG, immunoglobulins. Second line, sure, got it. Patients require intervention, so dangerously low, kind of what we talked about. Unless they're showing signs of bleeding, right, or having major issues, you got to monitor them. And then the treatments we already talked about. Secondary cause is splenectomy, and then at the bottom, so all the stuff that we're talking about now, right? Right, hematology consult. Dude, I got this kid, got ITP, his platelets are at 80. I'm not overly concerned there's something bad going on at the moment. However, I need you to go see a hematologist. Right? Because you don't know when it's going to transpire to something bad. And you don't want that on your watch. Right? You want to, hey, you've seen the specialist. Specialist says you can do X, Y, or Z, you come up with a plan for it. All right, hit. Any questions on ITP? Immune process, right? Autoantibodies attacking your platelets, only your platelets are affected. Sweet. All right, ITP, good to go. All right, this is another fun one. Heparin-induced thrombocytopenia. So path is behind it again. Antibodies to heparin PF4 complex, right? Platelet factor 4. Kicks into platelet activation, you get some clots, got it. Thrombocytopenia, 50% drop in platelets. Early on, you may get some thrombosis, right? And we'll talk about the 4T score in a second. What did we say our reference range is for platelets? Okay. So let's say a patient, their baseline walking in the door, their platelet count is 400. A 50% drop puts them at what? Is that normal or abnormal? That still falls within our normal range, right? So this is where I need you guys, again, a couple things we talked about, right? One, always have a high index of suspicion. Two, anytime you have the ability to go back and look at somebody's older labs to compare it to, you need to do that. Because if you just get that one isolated look and that patient's lab is 200, but they were inpatient, right? Because you guys are all gonna go and work inpatient medicine, and God bless all of you, because I dislike inpatient medicine, right? I do not like rounding on the same patient day after day for months. That's why I do ER. I can treat him and I can street him, right? Kick him out. I don't be somebody else's problem. Some die-hard, dedicated person who likes inpatient medicine. Right? So So you guys, hey, first day in rotation, you're inpatient, you're rounding, right? You get your little charts and taking your little notes on each patient, and you pull up the labs from the night before, and you see, yep, platelet count, 200, and you don't think anything about it, right? Yeah, that patient was getting heparin. Yeah, that patient 2 days ago when they got admitted, guess what? Their platelet count was actually 450, right? So if you don't do your homework and look at what their labs were before, you don't have something to compare it to, you could miss something, right? Or on the plus side, you could catch something. You could be the hero, right? You could be the one that say, rounding with the attendees, and you're like, hey doc, guess what? His platelet count was this when he came in. Any concern for hit? Right? So again, do your due diligence, right? Because this is where, when we take shortcuts in our business, it does not end well for us, and it certainly doesn't end well for our patients. Right? Do your due diligence. If you have the ability to look at whole labs, look at it, they have something to compare. It's easy to miss that. Thrombocytopenia, 50% drop. 4T score we're going to talk about, and then the platelet factor 4, got it. Management. The problem set that kicked this off was heparin. So maybe I want to stop the heparin. Make sense? Right? All right. Life-threatening, acquired complication. Yes. 5 to 10 days after heparin exposure. Right? And it doesn't mean that they have needed a whole bolus of heparin. Flushing a line with heparin could be enough to trigger this. Dose, not dose related. There you go. Flushes, yes, got it. At risk, right? Because they throw clots, they become hypercoagulable. And that hypercoagulable state persists for weeks or months after heparin. So what does that mean to you? You're worried about a patient that might clot, so what are you going to do? They're going to need to be on some sort of prophylaxis, right? Which is not heparin. All right, so there's the process, right? So heparin, patient gets exposed to heparin, it binds to that platelet factor 4, which causes in these individuals an immune response. The body forms an IgG to this complex, right? So then it kicks off, more platelets get released and get activated. So you start to throw those thrombi, you start to throw clots that activates your platelets. But this immune process is going on, right? So now the body is removing the platelets. So it's a double, like it says here, right? A double-edged sword. So you're losing platelets because the clots are forming, they're activated, but you're also getting the platelets removed by the spleen because of that IgG antibody. So your platelet numbers tank. There it is in pictorial form. Platelet factor 4, heparin comes along, it binds. The body decides it wants, for whatever crazy reason, form this antibody. Yep, attaches, and then whammo. Platelet activates, you get clots, and then the spleen starts to remove the platelets. So your platelet count drops. New onset thrombocytopenia in a patient 5 to 4 days after exposure. Again, just depending on what their baseline is, may say how quickly this really shows itself. Right. Decline of 50% more, we hit on necrotic skin lesions. Yes, right? And then the thrombosis. Diagnosis is usually clinical. So we'll talk about the labs here in a second that's associated with this. Confirmation of diagnosis may not always be available. Slow turnaround time. So there's highly specialized lab tests that we'll mention here. A lot, depending on where you are, you may not have that ability to get those lab tests like turnaround. Sometimes there's mail outs and send outs. So you could say, hey, I think the patient has this, I'm gonna go get some labs, but you need to take care of that problem set. You can't wait on your lab result to come back to confirm it necessarily, is what I'm telling you. All right. Clinical diagnosis. Yeah, so there's your wonderful ELISAs you can order, right, for the platelet factor 4 antibodies, sure. Thing is, you may not get them in time, right? At the end of the day, that might just help kind of confirm it on the back end, what you were dealing with. And the 4T score, we'll talk about here. Low 4T score, more predictive of excluding hit, right? So because it's a clinical diagnosis, that you need to act on before you can get your confirmation back to develop this wonderful thing, your probability. Right. And that's your 4T score. So if you go across, add it all up, come up with your totals, depending on their presentation, depending on what their thrombocytopenia, their platelets look like. If you end up with a number greater than or equal to 6, it's highly probable that that's what you're dealing with. 4 to 5, intermediate probability. Less than 3, low probability. Right. If they have a low probability, then you're gonna have to make a clinical decision, and they're probably not gonna treat it like HIT. Right. So your 4T score is gonna help you to say, yeah, this is probably HIT most likely. I need to do something about it and treat it like it's HIT. Right? If it's less than 3, then it's probably not HIT. I need to go look in to see what else might be causing what's going on. Right? That's kind of the way they use the 4T scores. Treatment, initiated as soon as diagnosis, yes. Kind of we talked about, right? You can't wait on confirmation labs. Yes, heparin is your problem set. So I need to discontinue the heparin. Begin treatment with DOACs. DOACs are great for this, right? What's your DOAC? Direct oral, you guys are better pharmacists than I am at this stage. Warfarin is contraindicated. Right? And when we talk about the thrombophilias, we'll talk specifically more to you about the hit of heparin. All right. When platelet count's greater than 100,000, then you can just go back to heparin if you need it. And then the ultrasounds, right? Because the early part of the disorder is you're throwing a bunch of clots, thrombi. So you do some Doppler ultrasounds to go looking for clots. Any questions on HIT?
Sure.
Right?
So does this only apply to like IV heparin? Like what if you have somebody that's on Eliquis for like the 3 to 4 month long term?
So it's typically like the lower molecular weights, usually the parenteral injectable IVs that pick it off.
Okay.
But again, nothing is 100% in medicine, right? So if people present with this and they've been exposed to heparin, you start going down this pathway.
Okay. If you have somebody on Eliquis, would you typically still do lab work to make sure?
Yeah, I would. So all of this stuff, right, and everybody's going to figure out their own practice patterns, right? Everybody has this sort of level of comfort, right? And early on, when you start practicing, you tend to practice a little bit more conservative, right? Which I tend to. And then later on, you'll see stuff like I had this doc, ER doc. So you have some people that we call cowboys, right? They just kind of do whatever. And this was a dude, like, patients, man, you get these 60-year-olds coming in the ER, right, with chest pain and stuff. They go, yeah, good, no, yeah, good, you're gone. Like that, like, right, clear him, because he got to that stage where he had that comfort level. You get like one set of tropes and he's done, right? Where at the time the standard is I get a set of tropes now and then I'll get one a couple hours down the road. Not rich, right? And we all develop our own practice patterns and comfort level. When you get to a certain end, you've seen enough, then there's something you're just going to let go.
Yes, sir. Thank you.
Yeah.
That 4T score chart, you want us just to know that 6 is.
I want you guys to know everything in black ink on all my slides. No? Is that not reasonable? So I want you to be able to interpret a result. All right. That's what I expect from the 4T score. I'm not asking you to memorize all of this stuff. I don't know all that stuff. That would be just wicked, right? That's unnecessary abuse. But if I give you a 4T score, then you got to be able to make a determination what I want to do with this patient. Right. Good. Did I kind of answer your question? All right. Treatments we talked about, yes, and anticoagulation, right? 3 to 6 months, yep. Subsequent, yes. So what kicked this off was heparin. Maybe in the future I don't want to expose them to heparin. Okay, make sense? And then the usual, yes, let them see a hematologist. All right. No questions on HIT. Easy day, you guys got all this, man. This class is super studly, I like it. Alright, so we're gonna talk about thrombotic microangiopathic disorders. Thrombotic, meaning what? Clots. Microangiopathic, what are we talking about? Small blood vessels. Hemolytic anemia, right? Hemolysis causing anemia. So again, when you get stuck on something, go back to the definitions and that should be able to tell you what's going on. I got clots, I got some hemolysis, I got low platelets, right? All right, two big ones we're gonna talk about, TTP and HUS. All right. Sharing of RBCs. All right, so in these conditions, we see this thing called schistocytes, and we'll show a picture of them in a second. But what's going on here is your RBCs are getting shared, and they're getting cut, and they're getting deformed, and that forms something called a schistocyte, which we'll see here in a second. And then you get evidence of hemolysis, right? It's a hemolytic process. Oh yeah, and thrombocytopenia, right? I form these thrombi, right? I'm eating up my platelets, so my platelets are low. They're your schistocytes. So there's a couple ways that these get formed, right, depending on what's going on. If it's a case of a microthrombi, so you get all these platelets that form, right, form this whatever, float someplace. As the RBCs are going past them, they're getting sheared, and they're forming these schistocytes. So in these small blood vessels, you get these little clots that all gather together, all these platelets, and shearing the RBCs as they're going by, and you form schistocytes. The other way you get those sometimes is, so heart valves, or aortic valves in particular. A patient with a really calcified aortic valve, right? As the RBCs go by that valve, they get sheared, and you form schistocytes. All right, TTP, HUS. In the case of TTP, that wonderful atom whatever deficiency, right? So you have a deficiency of this, and we'll talk about why this is significant. Because this is that cleaving enzyme for von Willebrand's. And because you lack that, you don't cleave your von Willebrand's, which we'll talk about here further in a second, and you get these huge platelet clumps. And then HUS, right? Hemolytic urine syndrome, that toxin from the E. coli 01787. You guys learned about that one in micro, I hope. Yeah, right. So that's where this notorious E. coli comes into play. There is the classic pentat presentation for these. So by definition, it's a micropathic hemolytic anemia. So guess what? I got hemolytic anemia. I'm using up my platelets, I get thrombocytopenia. Acute kidney injury. You see that more likely than not with HUS. That's where the kidneys take a hit. Neurological symptoms, sure, and fever plus or minus. All right. Diagnostic testing. The schistocytes we talk about, if you're talking about TTP, the problem set there is the lack of that enzyme. So obviously my enzyme's going to be low. And then with hemolytic urine syndrome, the problem set's what? With HUS, what's your problem set? That toxin, right? Which comes from the E. coli, so you would do culture assays to figure that out. Management, TTP, therapeutic plasma exchange. And with HUS, there's typically supportive care. Fatal without treatment. You might not want to miss it. All right, TTP specifically, if anybody wants to take a shot at that enzyme, go for it. All right, that's what we're dealing with. The ADAMTS13, right? It's a von Willebrand's cleaving protease. If I lack that, and we'll show a picture here in a second of what happens. Autoantibodies, yes, got it. Could be secondary. Whatever reason, I lack that enzyme. I lack that enzyme in sufficient quantities. And that's what it looks like. So the top is normal, right? So where that enzyme is, its job is to cleave the von Willebrand factor. If If I don't have the enzyme, as in the picture below, I get these long strands of on willograms, which just accumulates a bunch of platelets. Right? And then you can kind of imagine all that clot happening in a small blood vessel. And then imagine a small RBC coming in contact with that and create that schistocyte that we talked about. TTP, that atom TS13 deficiency. Good? All right. Presentation, median age, 40s, right? And females most are. All right, so anemia, right? It's a hemolytic anemic process. Fatigue, weakness, some dizziness maybe, shortness of breath, depending on what's going on, abdominal pain, bruising, DKI, right? The platelet problem said, the thrombocytopenic. Despite the severity, not all patients critically ill, sure. Not discovered until the labs reveal low platelets. Yeah, probably won't catch it. All right. The labs should be intuitive to you guys now, just by the name, the nomenclature, right? It's an anemia, microhemolytic anemia, so you know what your CBC is going to look like. What's your hemoglobin in your crit? No. It's a thrombocytopenic process, so no platelets. There's hemolysis taking place. You know what your hemolysis labs are, right? You should be able to walk the dog, whatever on your lab set. BUN and creatinine. Elevated here, we'll talk about this specifically. What's your BUN and creatinine measure? Renal function, right? All right, and then coagulation. Does it have anything to do with your coagulation factors? No, right? So PT, PTT tend to be normal. Is it an immune process? Is the deficiency caused by an antibody? No. All right, so your DAT is negative. And then in the case of TTP, right, your confirmatory, you need to check your assay of your atom TS13, atom 13. All right. Mainstay of treatment, therapeutic plasma. And there you go. Define, all right, HUS. So HUS is very similar, right? Again, a microangiopathic process, so you get all the same features. With HUS, you tend to hit the kidneys pretty hard. So this is where you tend to see that elevated BUN and creatinine. Tends to be kids, seen in pediatric population, under the age of 10 often. And what's kicking this off is that Shiga toxin we talked about, right? The E. coli 0157H7. It's the same, you get that thrombotic microangiopathic stuff. Colonizes the guts, the Shiga toxin, predilection for renal injuries. Right? So all this clotting and everything takes place big time in the kidneys. And this is kind of what it looks like. So there you go. Somebody eats something that's not so good, right? And a couple of days later, they get the diarrhea, fever, abdominal pain, bloody diarrhea, right? 90% of the time. So with HUS, expect to see some bloody diarrhea. And again, what's the patient population here? Kids, right? Cultures. So you'll see, right? Again, 85% of the time, nothing happens, right? It just resolves, takes care of itself. Spontaneous resolution, self-limiting disorders. But 15% of the time, things can go south, right? Here's your timeline, 5 to 10 days, got it, bloody diarrhea, vomiting, a bunch of EI symptoms, hematuria, hemoglobinuria, again, the predilection for the kidneys, right? Renal injury associated with this. Platelet problem, so you get the petechial rash, bruising, right? And then do you get the CNS involvement, seizures, strokes, whatever. Again, the labs should be intuitive to you guys, just based on the name of the disorder. Anemia, thrombocytopenia, got it. Schistocytes, got it. Hemolysis, so you know what your hemolysis labs look like. It's not a coagulation problem, so my PTT are normal, right? Again, not immune mediated, so my Coombs is negative. Here, your renal, right? Kidneys take a hit, and then how do you diagnose an E. coli problem? Micro labs, whatever, go check into that sugar toxin. But again, it's an index of suspicion, right? You're gonna see kids with diarrhea all the time. But does this kid look okay, well hydrated, and doing fine? Is there blood in the diarrhea? Because that's always gets your attention, right? Is it bloody diarrhea? You know, bloody diarrhea and fever. Bloody diarrhea, fever, and they look like they're behind on their fluids. Right? You gotta do some sort of intervention. Primary supportive care, fluid electrolytes. Right, so that's the key, fluid and electrolyte. Again, most of these patients are gonna do just fine, unless they're so severe that they need a transfusion. But most of this time, it's fluid and electrolytes. Antibiotics, why don't we give antibiotics in this disorder? Right, it's a bacterial infection. Let's get him on some antibiotics and get this kid cured. Exactly, right? So now you go killing all that bacteria, all that sugar toxin releases into the system and whammo. Right? What was the problem set? The sugar toxin. Right? Now we just released all that sugar toxin. Right? So that's why supportive care is sort of the way to go. You don't want to induce antibiotics. Anti-motility agents. What are we talking about here? Give me an example. Yeah, like loperamide. You guys are gonna have to figure out like your weirder stuff too, right? So you're gonna see a bunch of VGE, right? Viral gastroenteritis stuff. And you're gonna see it coming in the clinic. If you're on a ship, you're gonna get a run of it like crazy, right? You're out with your Marines, you're gonna get it sometimes, right? Wherever you are, whatever units you're attached to, right? It's gonna get some blast of VGE. And then you're gonna get dudes who are about to step on a plane maybe and travel, right? And they're going to the head every other minute. Do you want to give everybody anti-motility agents? Because that's what the dudes come in for, right? Hey doc, I'm about to get on the plane. Let me get some loperamide. Let me get something to slow this down. Is that the right answer? Again, you're gonna have to develop your own practice patterns, right? Because just depending, am I giving them something to slow this down and prolonging this problem set that they have? Am I potentially making it worse? Right? So if it's just a run-of-the-mill, you know, a couple episodes of loose stools, diarrhea, and after guys coming to you with diarrhea and fever and some other systemic stuff, do you want to slow that stuff down? Right? It's coming all your way. Good luck. Right? And you kind of have to figure out that balance, right? I'm about to fly across the world and I'm going to the head every 2 minutes. That can be uncomfortable. Right? All right. And then no NSAIDs. Why no NSAIDs? So NSAIDs also your kidneys. What filters your NSAIDs? Kidneys, right? And your kidneys are taking a hit from this. So I need to, you know, add insult to injury by throwing an NSAID on here. Right. So again, sometimes we have this thing in medicine where we want to intervene. We want to do something. I have to do something. You know, sometimes the best thing is just nothing. Sometimes the best thing is just some supportive care. Right? Make sure this patient is electrolyte good. Make sure they're well hydrated. Yep, and that's the same deal there. Right? So HUS, abdominal pain, fever. Talk about some of the neurological stuff. They present with a seizure. Right? Thrombocytes, yes. Renal insufficiency, yes. Right? If the kidney's taking such a hit that they need dialysis. Alright. So on milligrams, we just killed to death, so we'll just take 2 seconds and run through this. Right? Again, von Willebrand's, you guys noticed, deficiency, yes, affects platelet adhesion, affects factor VIII, presents mucocutaneous bleeding, right, the petechial rash, menorrhagia. Alright. Do you measure the von Willebrand factor? Yes. Ristocetin we talked about, factor VIII. Why is factor VIII decreased? Because von Willebrand is supposed to stabilize it, and your key treatment typically is desmopressin. And then other acquired things that can mess up your platelets, right? So, uremia, drugs we know about, right? The myeloproliferative stuff, don't worry about. We'll talk about that in our next block of lectures when we get to the oncology stuff. But again, how do these present? It's a platelet problem, and they present similar. And obviously, with uremia, and again, treat the underlying cause. You fix that problem set, and then the platelets will go back to normal. Right? This is a qualitative issue. Yep, got it. The drug-induced, right? We all know certain meds are designed in some instances, right? We give these meds particularly because they can help, right? Hey, let me put this patient on a daily aspirin, right? Reduce platelets, reduce their chance of clotting. But also sometimes an unwanted side effect. Sure. Discontinue the offending drug. If the drug is causing the problem, maybe if I get rid of the drug, right? Easy enough. Yeah. And there are some of the drugs, and you guys know these. Your aspirins. Right? And then the myeloproliferative, it's there. Don't spend any energy on that yet. We'll get to that stuff next go around. All right, platelet disorders, quantitative versus qualitative, right? And then you got to know your ITP. You have to know your microangiopathic processes. What's the two microangiopathic? CTP and HUS. And then looking at your labs, what key presentations, right? And can you talk yourself through these on a lab? And I think after today's class, you guys got this. Maybe before today's class. Any questions on the platelet disorders? Any questions on anything we've done so far? How much longer can I torture you guys today? Huh? All right. See you next time. Hit me up with any questions.
Good to see you, Mr. Ruggiero. You can come in early and start.